Welcome to Health Hats, empowering people as they travel together towards best health. I'm Danny Van Leeuwen, and I have worn many hats in my 40 plus years in healthcare as a patient, caregiver, nurse, informaticist, and leader. Everyone wears many hats, but I wear them all at once. We will listen and learn about what it takes to adjust to life's realities in healthcare's Tower of Babel. Let's make some sense of all of this.
I'm obsessed with the puzzle and opportunity of best health. My mission, after all, as Health Hats, is empowering people as they travel towards best health. When I think about best health, I include physical, mental, and spiritual health, and I define it as operating at peak performance as often as possible over time. Another way to look at it is that best health is living the best life possible given our genetics and biology, social circumstances, and physical environment. These are some of the determinants of health, and these are somewhat out of our control, but we have some limited control. I can't change my genetics, but with difficulty I could move somewhere else. Physical environment. With less difficulty I could increase my mobility with a handicapped public transportation pass. Social circumstances. The other determinants impacting best health we consider more often: medical care and personal behavior. So this week my thoughts are about equity in best health. Equity is that people have the same opportunity to achieve best physical, mental, and spiritual health no matter their social circumstances, their biology, their genetics, or their physical environment. I had a great conversation this week about equity with Amy Saunders, founder and president of the State of Inclusion. Speaking with Amy, I found that I was confused by the concepts of diversity, equality, and equity. I've used them interchangeably, but they're not. I appreciate the diversity of people. I appreciate varied religions, gender orientation, culture, attitudes, skills, abilities, backgrounds. And over the years, I've built teams with an eye to diversity because I firmly believe that there's strength in diversity. I learned about equality, which I'll define as leveling the playing field, from the work my civil rights activist parents did in the fair housing movement in the 60s. My parents sold their house in a red-lined, upper-class white neighborhood to a family of color. I've learned about equity working with people with disabilities, and now as a person with my own disabilities. And here I think equity means more for those who need it. For those who need it? Well, a person in a wheelchair needs more to be able to access a bathroom in an airplane. A teen just arriving to a public high school in the U.S. from a Syrian refugee camp needs more to be able to graduate. An 18-year-old with multiple chronic illnesses needs more to succeed in college. They all need more to achieve the same as everyone else. Another way to think about it is that think about a stadium being built. If they build bathrooms with equal numbers of stalls and bathrooms where people sit to pee as urinals where people stand to pee, that's equality. That all people who sit to pee use the same bathrooms is diversity. But people who sit take longer to pee than those who stand. So we need more stalls than urinals. That's equity. Okay, now let's go back to equity and best health. I think that bias impacts equity, which impacts best health. And there's different kinds of biases. There's systems bias, clinician bias, and patient bias. They all impact equity, and they all impact best health. So let's look at those. So system bias is also called institutional bias, and it's the inherent tendency of a process and a system to support a particular outcome. So what does that mean? Well, let's look at some examples. So one is inaccessible design. Instructions only written in English or only available by smartphone. Another is lack of diversity in management or staff. So management has different cultural backgrounds than staff, or nobody on staff speaks the predominant language of the patients or live in the neighborhoods of the patients. Another is occupational stress. That's an imbalance of job requirements on the one hand and resources and time to do the job on the other. Another system bias could be policy that interferes with the clinician-patient relationship, such as the policy to prevent opioid abuse restricts clinicians' ability to prescribe sufficient pain meds for a person in a sickle cell crisis. Okay, now, clinician biases. They could include associating non-compliance with personal characteristics. So, for example, thinking that not following instructions relates to how a person looks or their age. Selective or absorption of evidence, not accepting that women may have different systems of heart disease than men. Suspicions of social media, don't use Dr. Google. And selective listening, if it's a woman in pain, it must be in their heads. Patient biases are important too, and they include lack of trust of doctors or insurance companies, fear of hospitals, thinking we know more than we do, accepting whatever we read about health on social media in spite of what our clinicians tell us. So now that we've talked a little bit about equity and maybe hopefully understand it more, we have to figure out what to do about it. Amy Saunders suggests that that reaching for equity requires moving towards systems designed and built for inclusion and best health outcomes. Let's continue this conversation with Amy. She and I are planning to interview each other soon for our respective podcasts. Stay tuned. Equity is more to achieve the same. Subscribe to Health Hats, the podcast, on your favorite podcast player.
Hey, thanks for joining me. Follow me through my website at www.health-hats.com. See you around the block.